Hello and welcome to the latest episode of YouMatter. This is episode 13. Hi there, welcome back to YouMatter. Today's podcast is one that I've been wanting to do for a long time with my friend Dr Susanna Petche, who is an A&E GP, but also an expert on the topic of trauma, something that has been talked about and thought about a lot over the last couple of years, mainly due to the pandemic. But it's certainly an area that is gaining lots more attention and lots more interest. And when you listen to Susanna speak as an absolute expert on this topic, I think you'll, like me, realise that it's something that needs more attention, more understanding, and hopefully something that we'll be able to incorporate within the more general world of healthcare in years to come for the benefit of all. So sit back, have a listen to Susanna, who is just a font of amazing knowledge in this field of trauma. Enjoy the podcast and I'll be back at the end. Hello and welcome to session 13 of YouMatter. And as I said in the intro, I'm absolutely thrilled to welcome my friend Dr Susanna Petche, who is a doctor, GP in A&E, but also an expert on the subject of trauma. So before we get stuck into the podcast itself, Susanna, could I ask you to introduce yourself and tell us a little bit more about how you got to be working in this field?
Yeah, thanks, Jo. Thanks for the opportunity of talking to you today. So I've been a doctor for well over 20 years and always been interested in mental health. But it wasn't until really 6 years ago when I became unwell myself and was diagnosed with complex PTSD that I really understood what that meant. Or rather, I didn't actually understand what it meant. I didn't understand my symptoms. I literally thought I was losing my mind. And it was terrifying. And that led me to try and explore this and understand this so that I could really heal myself. That was the main driver. And then through that exploration and doing a master's in psychological trauma, it was like putting on glasses and I could see things in a completely different way. And it's completely changed my practice. And so now I integrate that kind of trauma-focused lens with my work as a clinician, working as a GP in A&E and an out-of-hours GP. And I've also been training in functional medicine. And I use that functional medicine approach and lifestyle medicine to look at helping people to heal themselves when they've got ongoing vague symptoms that are likely due to previous psychological trauma. I also teach around this because I just think it's so prevalent, and the more we can get people to understand how psychological trauma comes up, how it manifests, and how to help people, just the better it's going to be all round.
Thank you. So just to take it back a little bit, Susanna, trauma, the word trauma certainly has come into my vocabulary and awareness much more within the last 2 years. I mean, slightly before pandemic actually, but it's been a word that's been used a lot during the pandemic, hasn't it? And for people who might just be asking, well, what actually do we mean by trauma? How would you explain it to, say, someone who had no experience of it, or perhaps a non-health professional?
Yeah, so it's a good question, because I think it's become quite a term, a phrase that's been bandied around quite a lot since the pandemic. So trauma in a kind of traditional sense is a really dramatic injury. So a really dramatic event, and psychological trauma is looking at the kind of the psychological, kind of more the psychological side of it. But essentially, it is somebody who experiences a traumatic event, whether that is something that is physical or emotional. It can be any number of things. And it's also whether somebody has a perception of a traumatic event about to happen. So the brain doesn't distinguish between an actual event or a threat or a perception of an event. And then it's what happens afterwards. So not everybody who experiences a traumatic event goes on to have consequences of psychological trauma. but it varies depending on what the event is and what happens and their surroundings. Then people go on to have a consequence, and that consequence is because the brain hasn't quite processed that event properly and hasn't filed it away properly, so the nervous system becomes really affected, and there's like a lingering in the nervous system. And remember, the nervous system is not just up here, it's throughout our bodies. So we have psychological symptoms, but also very much physical symptoms.
And is this, so I'm sort of rephrasing it in my own mind and thinking, we obviously call it trauma for, because it's an easy phrase, but it sounds like it should be really what you do with trauma, or what your nervous system does with trauma. So is everything a malprocessing, or is it like different versions of a normal process? Or are we, when we talk about trauma, are we talking about a malprocessing of trauma always?
So yeah, so it's understanding that initial response in the body, so that so when people have either a perceived threat or an actual threat to themselves, then the body goes through a survival response. So some people call it survival response, sometimes it's called the stress response, sometimes it's called the fight, flight, freeze response. It's all the same thing. And that is a very normal response. It's to get us to survive. If we didn't have that response, we wouldn't be here. So our bodies and brains need that process for us to be around, for us to survive. But it's when that process isn't fully switched off, and the memory of that event hasn't fully been kind of integrated and processed, that's when there's a consequence. So trauma is another way of thinking about it, is it's a normal response to an abnormal event.
Yeah. So it sounds so similar to how we would explain chronic pain processing in physio. And presumably in the pandemic, the opportunities for processing have been problematic.
Absolutely.
Yeah, and potentially why we might have heard more about it and talked more about it.
Yeah.
So yeah, I mean, the pandemic is one reference point for this conversation, but also there's this TV program, isn't there? The serialization of Adam Kay's book at the moment, This Is Going to Hurt. And I know certainly myself and a lot of other health professionals read his book. Gosh, it's about 10 years ago now, I think, isn't it, when it came out? Certainly some years ago that I read it. But I've noticed there's been an awful lot of conversation on social media about it, mostly amongst health professionals. Maybe that's my bias because of my who I'm in contact with on social media. But I've seen everything from "This Is Going to Hurt," yes, it did, and I'm not going to watch it anymore, to perhaps non-health professionals talking about how it's opening their eyes. I don't know, what's your, I know you've read the book, and we were just discussing before we came on that we've seen some episodes but not all of it. What's your thought about the impact of, first of all, the book, and then maybe the TV serialization?
I think it's I think it's really interesting. I think I remember my initial response when I saw the book, and it being really that it was a bestseller, and like lots of people were talking about it. So it wasn't just my healthcare professional colleagues, it was like everyone around me. It was one of those books that kind of everyone had read and everyone had an opinion on. And I remember just being really confused at it being badged a comedy. And I got hold of a book, and then actually one of my children gave it to me for my birthday. They thought it'd be a great idea. They were very little at the time. And I just didn't find it funny. Because for me, it was too realistic. It was too much what I'd experienced. So I haven't done, so Adam Kay was an obstetric gynecology registrar. I didn't train in obstetrics. And so I had to do part of that as my medical school training. But as a qualified doctor, I didn't work in that area. And as my training as a GP, I kind of stayed a level below that. So because I trained as a GP, I became a GP registrar, and then on to be a GP. But I did all as kind of SHO level. So there's kind of references in the show about the SHOs he works with. And that experience of being exhausted, doing really long hours. A lot of the time, I remember we were doing unofficial overtime, but it was just expected that we had to do it. Being told you wouldn't get a reference if you didn't do it, which now you consider it just be ridiculous. You wouldn't never talk to someone like that. And being in situations where there wasn't necessarily the senior cover, so the way that in the show the consultant's always away, that's changed now. So just the way that was then is very different to how things are now. So, and there's advantages and disadvantages to that. So now there's a lot more senior cover around, which is good, but as a consequence, then people are working much more in a shift pattern. So rather than working kind of 24 hours or over the weekend, you'd be up for goodness knows how long with kind of snatches of sleep in between. There's now kind of, you do day shifts and night shifts and early shifts and late shifts. And although that's better from a sleep perspective, and it's obviously better that you've got more senior cover around, you're not as much attached to a team. So what used to happen, what happened when I was training, is that you were part of what was called a firm, which is with a consultant who had a registrar and then an SHO and then a house officer. And you were kind of in a unit and you belonged to that team. And everyone kind of knew where you were, and you got to know those doctors and they got to know you before you rotate, because as part of your medical training, you have to keep rotating around different specialities. And there was much more camaraderie around that. And now, because of the shift patterns, you're attached to a speciality rather than kind of a consultant. So it's much more fragmented. So that support and that camaraderie that we had and really relied on and kind of really lent into for support, that's now really lacking. So I know now where, yes, you've got the senior support, which is good, and there's more sleep, which obviously is good. That camaraderie and that kind of that structure around it, that's lacking. So I know some juniors are feeling quite lost around that and not having that clear structure.
This was the cynical side of me when you said it's changed, and now the consultants are a lot more present and people are doing more equal shifts. I immediately thought, oh gosh, so does that mean all the poor SHOs of your young era now heading into consultant era don't get the payback that you would have got previously, when I hear people say, I survived to this point and now I get my reward.
I mean, it is actually, I mean, for me, it's actually, that is one of the reasons why I trained as a GP. I mean, that's very much so that I really struggle with staying up overnight and working over, I mean, as would anyone, but the shift pattern of it's, they started to bring in shift patterns as I was doing my training, my kind of later training, and I really struggled from that switching day and night. And I started off training to be a pediatrician, so a children's doctor, and I could see they were talking about the training coming in, that in the future consultants would be then living in, staying overnight in the hospital and being in the hospital and doing that shift pattern. And I just thought that there's no way that I can do this for another 20, 30 years. Like for me, it needs to be a finite kind of time. And that's, I mean, it's not the only factor. There are many reasons why I left hospital medicine, but that was one of the factors.
So just going back to the humour side of the book and the TV programme, and Adam Kay is a very funny man, and I believe he's a comedian, or definitely no one would argue that he has abilities with humour, if you want to dissect it and totally take the magic out of his humour. But to me, the book was full of, I guess, what would be called gallows humour. Which, I know that's quite a recognised survival strategy amongst medics, isn't it? So taking it back to trauma and processing, what are your views on the sort of the benefits versus the problems associated with that survival mechanism, I guess?
I suppose I just kind of, if I can go back a step further,
Mm.
um, that the importance, I think, of this book and the program is that it's getting doctors, is like you, I've seen a lot of kind of talk around it on social media within forums, talking about how, and using the words of how their training was really traumatic. And I think that there's been, it's a very normal trauma response to minimize and kind of diminish any traumatic events, because that's how we cope and how we survive. So that people have kind of diminished it is very, it's a normal response. But then to see it on the BBC or to see it on a bestseller list, it's there. And so it's harder to ignore. So people are starting to recognize actually how their training was traumatic, and maybe how some of the things that they experienced were really quite traumatic. And so it's understanding that in the context of trauma, that it's trauma, or the kind of the consequences of trauma, it doesn't necessarily need to be the person who's going through the event. It can be if you're bearing witness to something. So if you're bearing witness to repeated traumatic incidences, or repeated, you're hearing stories about repeated traumatic people describing their lives or incidents that are really traumatic, or looking at images that are really traumatic, then you yourself as kind of as the observer can get affected. And that's then called secondary traumatic stress, or vicarious trauma. So vicarious trauma is like a step along from secondary traumatic stress. And those symptoms are very much along the lines of post-traumatic stress disorder, and we really under-recognize that.
Yeah.
So that's where that becomes really important for healthcare professionals. And as you say, a coping mechanism is that release of having someone to share the circumstances, what's happened. And part of that processing of the witnessing the trauma, bearing witness to the trauma, is talking about it, is that camaraderie. So that kind of sharing of that experience, and normalizing it within the context of what's happening, that can be really healing. So that Gallows humour is something that is really important within that process of the kind of, that processing and healing, and so that it minimizes the impact to the individual healthcare professionals. But it's then it's about it kind of staying contained. So the problem is that when that becomes witnessed by people who don't understand the context, who don't work in that environment, it can sound really callous and uncaring. When, from my experience, it's something I've witnessed a lot in my, well over 20 years working and training, that the people who talk in that way after, extremely stressful periods of work, really difficult events happening at work, are the kindest, most compassionate doctors. Not every doctor is. There is always a variety within every profession, but I think it can give the impression that if people use Gallows humour, then they don't have a good bedside manner, they're not compassionate, they don't care about their patients, when actually it's a really important kind of tool to use. That doesn't mean that there's an excuse for being cruel and unkind to patients, or racism, or anything like that. That's not in any way condoning that or making excuses for that, but just where that humor becomes edgy and kind of that, that phrase, that Gallows humor, it's important to understand it within the context of where it kind of comes from and where it starts.
That's really interesting. That's changed my view of it a little bit, because I guess I wouldn't, as a physio, experience it in the moment when it's most useful. And I can see how perhaps if there's a tendency to rely on it too much and too long after the event, it can then be almost a shutting down process, or a block to good processing. And maybe even you then reading the book, which is obviously very post hoc, and definitely not you hearing a doctor talking about that after a traumatic event has just happened. Maybe that's the difficult context, because its best use is, as you say, in that almost immediate survival period just after an event.
Absolutely.
You also made me think about a question I was going to ask you next about me as a physiotherapist, but I guess other clinicians and allied health professionals might relate to this, that sometimes when you watch or read things like "this is going to hurt," or you just hear medics talking to each other, I've heard the response so often, "Oh God, what the hell am I worrying about then? My job as a physio is manageable hours. I don't have to deal with blood and gore and often life-threatening events. I have nothing to complain about." And I'd love you to answer that, but you did say something which made me thoughtful in your last answer about it's that secondary trauma thing, just being in an environment where you hear those things. But I won't answer my own question. You tell me what you think.
No, but exactly right. So it's I mean, you could argue that therapists are sat in a comfortable, warm, calm therapy room, but it is very, very recognized that therapists very much can experience secondary traumatic stress and vicarious trauma. And that's where the research around this really started, actually, and the idea of it being something that's relevant to healthcare professionals is relatively new. I mean, obviously it's relevant, but the research and the comprehension that it's relevant, that's relatively new. So it doesn't matter. It's what you hear and what you're exposed to. And again, it's kind of the context around it. So when you're saying you're not exposed to kind of blood and gore and life-threatening events, if you are, we're all healthcare professionals and allied healthcare professionals because we want to help. We have skills and a knowledge and a curiosity to help and enable the human body to heal and to reach and live its full potential. And we all then specialize in different areas that we're interested within that. So if we are in an environment working where we can do what we have been trained to do, and it is along the realms of what we trained and what we expected, and that we can work well within that, then it feels like we're doing our job well. So for example, if we are seeing patients, if somebody has some kind of accident or a massive heart attack, or someone's bleeding terribly and they come into an A&E department, when the team's there, you've got all the equipment, you're fully staffed, you immediately can help that person, and you're doing everything to the best possible ability with the best possible care, and then that person is going to get the best possible aftercare, then that feels good to be part of that. And if you then have the ability to chat and debrief with colleagues and have that camaraderie around you in that space to just have a chat if you need to, then that again just helps to ease it. Not to ease it, but to kind of to help process it, and to help you then just file that memory and process that working memory in it's part of your job, and that's job well done and something you've done well and that you're really proud of doing, and that's part of your work. If, however, you're working in constraints where things are constantly changing, for example, in a pandemic where, do you wear full PPE? Don't you? Do you resuscitate with PPE? Don't you? Is it the right PPE? The staffing shortages that are rife throughout the NHS now, where ongoing aftercare and rehab isn't what we would like it to be, that's then very difficult because you're working in a very different environment to what you thought you would be training in. And if then, because there's so much pressure to work harder and faster and better because there's less people around, less staff around, there is no space for the debriefing. There isn't space to have that kind of camaraderie and that connection of, oh, that was a really tough case, wasn't it? And yeah, you did this and I did this. And
Mm.
to just have that kind of debriefing, then we internalize it and we take it home. And we can see, we're like, a very clear example that was talked about a lot within the pandemic when it was particularly bad. And I don't know who kind of came up with the idea where this started, but particularly around ITU departments, intensive care departments, that they had this idea of a wobble room. So that they had a kind of a safe space that was next to the department where staff could go in and just have a moment to chat, to debrief, to just let go and let their emotions out. And just doing that in a very informal way was incredibly healing for those people. And that wasn't everywhere. It wasn't something that was used everywhere. It wasn't something that was valued everywhere, but it certainly really helped people. So it's showing that, it's kind of going back to that, the wobble room as a kind of kind of weird extension of Gallows humour, that idea of just being able to just have that letting off steam so that you can just then have a chance to just unwind with it.
Yeah, and actually really interesting, the last podcast episode I did with Felicity Thau was about talking about our failures as physio. And if I take it now to the very different context, in that a lot of people listening to this podcast may be working in the NHS in the teams as you describe, and a lot will be working on their own in clinic rooms. And we were talking about the fact that we don't even mention our failures in inverted commas, and we label them failures because we don't have any other reference point other than ourselves, when our perception is that, ours was the only input with this person, therefore if something goes wrong, it's definitely our fault. And without that ability to talk about the other people in that person's life, never mind all the other health professionals, but their family, their kids, all the other things that influence their well-being, it can become, as you say, incredibly internalized. And I'd forgotten about the wobble room, even though I was actually involved in some of those in the pandemic. But we've been just mooting ideas with a bit of sort of wry smile. Felicity at the end of her podcast said what we need is the Society of Average Physios, and somebody's actually formed a Facebook group called
that. Really brilliant. Yeah,
but kind of a version of a wobble room, isn't it? A space where you can just come out and go, oh, I did this thing today, I was such an idiot, and for everyone to go, yeah, I'd done that too, or gosh, that must have been awful, let's talk about it, let's laugh about it, and that safe container for those feelings, really.
Yeah. There's an analogy that I think works really well here. So there's a really well-known trauma expert called Babette Rothschild. She's written a number of books, and she talks about this idea of having a Coke bottle. So if you have a kind of a Coke bottle that's shaken up, it's just going to explode. But if you just release it a little bit at a time, then it just lets it out. And I think that's where I see that camaraderie at work, that if you can have that space to just vent and air things out in a safe space, that it's not going to be taken out of context, then that can just have that bit of release. But when that's taken away, for either because departments are too busy or because people are working on their own, I think a lot of that happens in general practice. People are just kind of stuck on their own. And it's so true what you say, that idea about making mistakes, because we don't have that comparison with someone else, and if we don't share that, then we can just think it's us that doesn't know properly, or that we've done it wrong, and that we're inadequate in some way, whereas actually we're just normal. And so sharing that can just be so helpful.
Yeah, definitely. So we can talk a little bit more in a moment about things we can do to help ourselves and support others, but how might people recognize that they were suffering from some kind of trauma processing problem?
So it's quite a big question.
Sorry.
Right. So essentially, there's lots of different ways. It may be it may be something really obvious. So it may be that somebody has gone through something that is recognized as being really traumatic. So it may be that for example, that they've been through a really bad car accident or train accident, or something like that, and they're just struggling to get beyond it and get back to work and get back to having relationships, friendships, and feel like they're getting back to function, and that's something that's persisting for more than a few weeks. So it's understanding, it's going back to what I was saying at the beginning, that this is a normal response to an abnormal situation. It's normal that, for example, if you're in a car accident, you're going to be affected. That's obviously going to happen. That makes us human. But if it's something that is lingering and there's something just persisting and staying for weeks and weeks and weeks, then that would be something that I would question. But it's then thinking, if something, that, like I mentioned earlier, what a typical response to trauma or traumatic event, if it's something that's really affected us, to just minimize it and to kind of compartmentalize it and put it away and diminish it as it wasn't really that bad. Other people have worse stuff happen. I'm okay. I'm here. So I just need to get on with it. So if then we find that we are thinking about that situation a lot, or that we're having certainly nightmares about it, or if we find that we're avoiding doing things, coming back to, that really simple example of having a car accident, if that's on your way to work and you just notice you're just always taking a different route and you're not going down that route, it's like, well, there's kind of something potentially that's there. But for some people, it's something that's so pushed down and ignored that it can be really delayed. So it can be something that people don't really recognize and acknowledge for years, even decades. And that's extremely common. So it may be that somebody, for example, but I mean, basically it can come out in, endless numbers of ways, but it can be with really vague ongoing physical symptoms. So it can be, for example, and this is not to say that everybody who has these symptoms has experienced trauma, but there's a big overlap. So it may be somebody who's experiencing chronic pain. It may be somebody who's experiencing gut symptoms like IBS. It may be somebody who's experiencing autoimmune conditions. It may be somebody who's experiencing things like fibromyalgia or chronic fatigue. It may also be somebody who is appearing to function really well, but really struggling to maintain relationships. It may be somebody who looks like they're doing really well at work, but they actually just never stop working. They never go home. They're always busy. They always say yes to everything. And they're being so busy to fill their life so much that they don't have time to stop and feel what's going on. And it may be the opposite. It may be that they withdraw and they're really struggling to work and have the motivation to work. So it's a whole host of things. It can look like resistant depression, and it can look like resistant anxiety, usually kind of a combination of both. But it can be kind of all or nothing. And it's understanding that people can function really well, and not only appear to function, but they can function and then have this side where they're really struggling and feel that duality is somehow wrong, and that means there's something wrong with them. And often then, because of that, they don't say anything about it and think, well, it's just me and there's something wrong with me. Actually, there tends to often be something underlying that, which you absolutely can get support with and get better from and heal from. So the important thing to understand is there's absolutely a way out. It doesn't mean that someone needs to sit with that all the time, and that's just how they are. And just to reiterate again, it doesn't mean that everybody who has all of those symptoms has trauma in the background. That's really important to say that.
Well, thanks so much, Susanna. That was a big question. I realise now, and apologise, but your answer was brilliant. And I'm sure everybody listening is the same. But as you were talking, so many people in my life and past life were coming into my mind then. And what you said at the end was important too, that it doesn't mean that all those people are suffering from trauma, but this it's a tricky problem, isn't it? Because
Yeah.
there's elements of all sorts of personalities that rings bells for. Yeah, brilliant answer. So on the back of that then, what sorts of things, and I'm sure this is an equally big question, what sorts of things might we do now to, if we personally thought we might be suffering from some element of trauma, or if we're trying to support somebody close to us who we feel might be suffering?
Yeah.
And I appreciate that could be on a whole spectrum of severity.
Yeah, so I think it's understanding if we've either personally or we can see with clients or patients really efficiently packed it up and packaged it up and kind of put it away. Unpacking that takes skill and time, and it's not something to be undertaken lightly. So it's really important, just thinking about that Coke bottle again. If you suddenly take the lid off, it's going to explode, and that's going to be really difficult. So really if you suspect it, either in yourself or in someone around you, being really, really gentle and just giving space to that. That's really important. So if it's something that you suspect in someone around you, in a client or in a patient or someone close to you, sometimes just asking that question, is there something that's happened in your past that you're still thinking about a lot or really preoccupies you a lot? Often then that gets someone kind of thinking, well, actually there is. Sometimes just that suggestion that maybe there's a link with somehow some of your struggles to move on, some of your physical symptoms, some of your anger outbursts, some of your ability to not leave work on time may be related to that. And you might find that someone says, don't be ridiculous, not at all. And then they're just not ready, and you just have to accept that. So someone needs to come to it, an individual needs to come to that point on their own, and you can't force that anyone to come to that. If someone's interested in looking further, then speaking to your GP would be a good point to start, and just kind of asking about that. There is more awareness around that now. There are a number of helpful books to think about that maybe you could list that we can have a think about. So there's one that's very well known called The Body Keeps the Score by psychiatrist Bessel van der Kolk. There's another one called Healing Trauma that's a very thin book by somebody called Peter Levine. They're really good starting points to just start to explore that, and to start kind of thinking about that. There's a clinician, another Canadian clinician called Gabor Mate, and he's got a number of books and also a number of videos and interviews on YouTube that are also worth exploring. And he's got a film out called The Wisdom of Trauma that's kind of, you can watch through various social media channels, that's worth having a look at. But there are a number of things then that we can do ourselves to try and help, and that we can kind of recommend to somebody to help them. So essentially, when we are, or if we are have experienced psychological trauma, and where there's consequences of it down the line, so where we haven't kind of fully processed it, what happens is that immediate response is an acute stress response. And that should, like I said earlier, that should happen. That gets us to survive. But when it's not switched off, it goes on to become a chronic stress issue. And when we have chronic stress in our bodies, that leads to inflammation. So if you think about inflammation as being like a fire, like, if you imagine like an insect bite or a cut from something kind of gardening, or something that's starting to get a little bit infected, where it looks hot and swollen and angry. So if you imagine that kind of happening throughout the body and the brain, so neuroinflammation as well, everything can function, but it's just not going to function to its best ability. And depending on where that comes out more, then you're going to have different symptoms. So if there's more neuroinflammation, that may come out more like anxiety and depression. If there's more in the body, then it might be more pain or more gut issues or autoimmune conditions. So the aim is really to try and calm inflammation. So if we can calm inflammation and calm the nervous system, then we're going to feel better. So very quick and easy way to calm the nervous system and therefore calm inflammation is by doing breathing exercises. So doing really simple breathing exercises, just even a couple of minutes at a time, and even doing that, even once a day, but if you can do it like 4 times a day, that is a really, really, really great place to start, that absolutely will have an impact straight away and can really help to start rewiring the brain. So there's breathing exercises that people can look up. There's box breathing or 4-7 breathing, probably the best known ones, and they're really easy to do. So 4-7s breathing is where you settle somewhere where you feel safe and you breathe in for the count of 4 and out for the count of 7. And it's trying to use not just your kind of upper chest to breathe, but trying to use your whole lungs and making your belly move when you're breathing. So in for the count of 4 and out for the count of 7, and just doing that for 1 or 2 minutes, and doing that a few times a day if possible. I put reminders on my phone to remember to do it. And then if you do that as a regular practice, then when you're feeling particularly anxious or something difficult's happened, or you've had a difficult client or something, then you can just quickly do a couple of rounds of that breathing. And because it's familiar to your brain and body, then it just kicks in and works really quickly.
So this is such a horrid question, I apologise. What's the physiology behind that then? So a breathing exercise to actually settle neuroinflammation, how does that work physiologically?
So the stress response is in a simplistic way is mediated by the sympathetic nervous system. So within the nervous system, within our bodies, we have the voluntary nervous system. So, me saying, I want to move my hand and I'm volunteering, I'm voluntarily doing that. And our autonomic nervous system, which is kind of automatic. So that controls our breathing and our digestion and our heart rate. And it also mediates our survival response. Because if you think about it, if a lion was to jump through whatever window you're in, you don't want your thinking brain to go, but we're in England. Why would a lion be coming through the window? You want to get to safety. So it's the part of the brain that mediates all of this is called the limbic system. So it's a primitive part of the brain that reacts a split second before your thinking brain. And that's all designed so that we survive. So that survival response is mediated by the sympathetic branch of the autonomic nervous system. So the sympathetic branch is all to do with kind of everything being heightened and hyper. So it heightens all of our senses, it increases our heart rate, our breathing rate, and it diverts blood to the areas that are needed for survival, like your big muscles, your heart, your lungs. And it diverts blood away from the areas that are not needed for immediate survival, like your gut and your reproductive system. Because if a lion's chasing you, whether you digest your food is irrelevant. What should happen is then when the threat passes, then if you look in the animal kingdom, what they do is they shake to discharge the excess adrenaline, and then the body goes back to homeostasis. What we tend to do as humans is to suppress that because we're embarrassed and culturally, societally, we don't kind of shake or discharge that immediately. We hold it all in and suppress it down. And that's when we start to have issues because it's not processed properly. So with the breathing exercise, when you breathe using your belly, which means you're using your diaphragm to breathe, so that domed muscle that separates the lungs and the abdominal cavity, and when you breathe out for longer than you breathe in, they both engage the parasympathetic nervous system, which is, if you like, the other side of that nervous system. They can't really work together. So it's either sympathetic is like the fight, flight, freeze response, and the parasympathetic is nicknamed the rest and digest. So you can change your breathing. We both, so this is the thing with breathing, it's both automatic and something subconscious, but it's also something we've got full control over. So by us changing our breathing and using our bellies to breathe and breathing out for longer and slowing our breathing down, we can force our nervous system to switch into the parasympathetic state, which then starts to regulate the nervous system. It starts to bring the gut online, the reproductive system online, to get everything kind of going back to homeostasis.
I really hope I've just asked you to explain things that people at home are going, oh, yes, I knew that. Actually, no, I don't hope that. I apologise if it was that. But I hope that I just asked the question that everyone thinks they sort of know what you're going to say, but it's so helpful to have it explained. Gosh, that's brilliant. If you can just imagine you in front of the patient explaining that, and it would make total sense. But you do hear a lot from patients, oh, everyone tells me to do breathing exercises and they make me worse. If anyone tells me to do breathing exercise again, I'm going to do this, that, and the other. So it's that kind of explanation and the revision of that for me as a physio actually is really helpful. Thank you. Slight diversion again. You mentioned Gabor Mate, and I've read his book. Oh, you might remember the title, Susanna. It's not on my tongue at the moment. It's one he talks about generational trauma in it. You might talk about that in all.
When the body says no.
No, it wasn't that one.
In the realm of hungry ghosts.
No, keep going. It'll come to me while we're talking. But I remember when the book was recommended to me, the person who recommended it very wisely said, when you read this, don't interpret it that whatever happens with your children is your fault, because that's not what he means. But I did get that, and it was a really
hold on to your kids. Is that it?
No.
He's written 4. So there's In the Realm of Hungry Ghosts, Scattered Minds is about ADHD. Right.
Scattered Minds.
Yeah.
Yeah. So if it's not, that trauma can be genetically passed down, how do you explain the manifestation of generational trauma as he describes it in that book? Because he starts in the book, doesn't he, talking about immense trauma in the war as being separated from his mum, and the trauma of being a Jew in the war, but then goes on to describe very openly how all 3 of his children have been diagnosed with ADHD, and he describes that as an example of generational trauma. So, is it in behaviours? Is there any genetic element? What's your understanding of that process?
Yeah, I mean, I think it's something I certainly wouldn't have understood 5-10 years ago, but that concept of generational trauma and epigenetics is something that we are starting to understand much more now. So epigenetics is the idea that our lifestyle and our environment can change our DNA. So we are born with obviously certain DNA, but what's expressed and how it's expressed is very much dependent on our lifestyle and our environment. So we may have a predisposition towards something, but it may not happen if we change our environment. So it can get switched on and get switched off. And that's the positive thing. So it means that actually we can heal. So it's the point of understanding that for me, so my personal life story, when my mother was born in 1942, and my grandparents were Hungarian German, so they were ancestrally German but lived in Hungary, and their families had been living in Hungary for hundreds of years, but they spoke German. And the Second World War was a horrific time for them, and they were refugees and sent back to Germany. So when my grandmother was pregnant with my mum, in a baby, when it's still in utero, it has the ovaries. So a baby is born with all of the basically the eggs in its body that it will use if that child grows up as a woman and wants to have children. So half of my DNA was in my mum when my grandmother was pregnant. So my DNA will have experienced that trauma that my grandmother went through. And then my mother growing up with that. And so how my mother has been affected by that will then be in my DNA and then in my children's DNA when my mum was pregnant with me. So that's how that can get passed on. And there's very much we can see, for example, how there's a lot of, they use the second word word a lot for research and looking at epigenetics. For example, there was a lot of research done around the Dutch families who experience, there's a particular winter that's kind of nicknamed the hunger winter, so where many people starved because there was no food, and the descendants of those people, there is a much higher incidence of type 2 diabetes, and that's changed their DNA expression because they were starved. That any food that came in, it was the body kind of held onto it because they were starving. So that's then altered the DNA expression so that it will hold on to anything. So then obesity and type 2 diabetes, it makes sense that it will be more prevalent. So it's understanding kind of the context around it. And it's fascinating, isn't it?
Yeah, it sounds almost like evolution on speed.
Yeah. Yeah. And I think it's something where there's a phrase, a kind of term that's used in functional medicine training that I just think so useful to think of, that our DNA is a loaded gun, but our environment and lifestyle pulls the trigger. And so when people say, oh yeah, but my family had this, that, and the other, so, it's just going to happen to me. That's not the case. We've got the power to change what happens and change how our bodies express it.
Oh, that is really fascinating. But it does also possibly give an explanation, if just thinking about you saying to patients, is there something you remember in your past? And it may not be that they're resistant to talking about something. It may just be that they literally cannot think of something. But if it is, in a previous if what's being happened is triggering of a trauma in a previous generation, then that is going to be hard for them to directly piece together, isn't it?
Yeah, I think it's rare that there would be, for example, say that somebody's grandparent has had some really horrendous trauma history, and then that when that individual, from the moment they were pregnant, their mother was pregnant with them, so the whole pregnancy and their whole childhood, both parents were completely unaffected by their parents' trauma, and that they were completely, wholeheartedly perfect parent, unaffected. That's really rare. So it may be that there's an element of it being inherited, but it then will have shaped the way that parent parented that child. So there's only when then that parent really takes on board and understands what's going on, and they heal their own kind of stuff, that then that can start to impact going forwards. Wow. And that's not to blame, and that's absolutely not to blame the parents.
No,
it's not to lay any blame anywhere. And our understanding around this has evolved so much in recent years. And for some people, it's literally just surviving day to day, and they don't have the space and ability to explore any of this. But it's I'd always say there's never just that complete, rarely that totally kind of pure, if you like, that it's just generational trauma. It's because it's impacting going down the line.
Yeah. Gosh, I could do a whole podcast on that, Susanna. I'm aware of time though. I know you've got to go on your school run, haven't you? But just to wrap this up, do you want to talk a little bit, Susanna, about how your work has changed? Because I know you're going through quite an interesting transition at the moment, aren't you? I'm enjoying watching that from a distance. But how are you sort of integrating this in your work now?
Yeah, it's like I said, when I started learning about this, it was like putting on glasses and just seeing things differently, and realizing not just people in front of me, patients in front of me, but other patients that I'd treated in the past, and just thinking, could have done that a lot better. And I pick it up all the time, every single day at work. And there are sometimes where there just isn't the time to explore it. Sometimes I mean, I frequently every day print out how to do 4/7 breathing for patients and give them a lifestyle prescription of what to do. And a lot of the time it's just explaining to someone that link, that they're not going mad, they're not making up these symptoms, that there is a really clear link to what's going on. And that there are ways around it. There's ways that they can help themselves. So, doing breathing exercise and changing what they're eating, and, having less processed food and less sugar, and eating more vegetables and getting daylight, all of those things that seem very simple, but have a huge impact on the body. So it's changed certainly how I practice day to day in an A&E setting, but because it's an A&E setting, it's very difficult to really have the time to go through it in detail. So I have started working as a private clinician to combine all of this, just to have more space. So really having the time to properly go through somebody's history and to then be able to follow somebody up, because the problem in A&E, you hopefully only see them once. So being able to follow somebody up and really have an ongoing plan with somebody. And for some people, once is enough. And for some people, they need a couple of follow-ups, and then, we have a plan and they can take that forward. And the other part of that I'm starting more recently to explore is looking at teaching. So I teach around this idea of how psychological trauma impacts medical school teaching and communication within the healthcare setting to doctors at Brighton Sussex Medical School. But I'm seeing more and more, looking in, for example, in the coaching field, how having a trauma-informed awareness of how we can interact with people could really help. So I'm exploring teaching more into those areas, just because I think if we can really get as many people as possible to really understand trauma for what it is and not be so afraid of it, recognize it, so that we then can treat people differently, which means that they're going to get to healing quicker, and then try and prevent it and the knock-on impact for those around them. The world's going to be a better place.
Absolutely. And I'm so glad there are people like you. Well, I don't know anyone except you doing this, Susanna. You're my kind of window into this. But yeah, hearing you talk about that and that ripple effect, definitely as a coach signing up to your course to become better trauma informed. But can I just say a massive, massive thank you on behalf of everyone that you're going to impact with this work, because it's so important. And I love listening to you talk about it. You just explain things so brilliantly, and take the fear out of trauma, which sounds like an oxymoron, but it's so useful to have people like you explaining it in the way that you do. Thank you so much.
Thank you.
Thank you for being a guest on YouMatter. So
thank you so
much. I'm sure people will be interested to read more about what you're doing, Susanna. Susanna is famously shy at sharing ways that people can get hold of her, but I have pinned her down to at least making sure that she shares her website with you. So, Susanna, can you let people know who will be desperate to find out more and get hold of you, how they can do that?
Yes, so my website is just my name. So it's www.drsusannapetche.com. So it's Dr. Dr. and then SUSANNAPETCHE.com. And I have an email address, which is drsusannapetche@gmail.com. But you can get in contact with me through the website. Any kind of questions that you have, there's a space to do that. I'm also on LinkedIn with the same Dr. Susanna Petche. And it'd be great to get in touch. It'd be great to, answer people's questions and talk more about trauma.
Brilliant. I'll make sure those contact details and the books and resources you mentioned go in the notes with the podcast. Thank you so much. I will let you go on your school run.
All right. Thanks very much, Jo. Take care. Bye.
Bye, Susanna. I hope you enjoyed that episode. I'm sure you did. And I'm sure, like me, you've learnt an awful lot from Susanna, who's such an expert on the topic of trauma. I'd be really interested to know what you thought and what you're going to take away from this episode. If you have any thoughts about how you might take this into your work life, family life, how it's affected you. I'm sure also that lots of you will want to follow up and check out more of Susanna's work. Please do go and look at her website. If you've got particular questions, then get in touch with her. She's always so willing to talk, and her motivation really is to educate as many people as possible about this topic. Okay, so I will be back for episode 14, which is a kind of revisit of failure, but in a positive way. I'll be looking at ways that we can manage our feelings around failure and make sure that it isn't crippling us and making our lives difficult as clinicians. Take care, and in the meantime, if you are a busy clinician looking after people in all spheres of your life, then take a moment for yourself. Don't forget that you matter.